Hello, it's me again. Apparently, I lost the PowerPoint on the lecture, so I'm redoing it. And I am so excited to do so. If I can get this thing to work. Okay, rules of life. The first rule is air must go in and out. So, what does that mean that air goes in and out? I want you to think of everything it takes for the air to get in and to get out. So, you have to have a hole, your mouth or a hole in your throat there, like a stoma. You have to have a tube that connects that hole to your lungs. It helps to have two functioning lungs. Some people can get away with one. You have to have intact ribs with muscles that actually work, contract and spread those rib muscles out. And you have to have a working diaphragm, and that diaphragm has to contract and drop. That creates a negative pressure in the chest, and then air will enter that negative pressure area. For this to happen, the chest wall must be intact because if you have a hole in there, then you're not going to change the pressure in the chest. It won't become negative and air won't go in and out. Um, think about if someone has a flailed segment for the ribs, that means the ribs are not nice and rigid and able to spread appropriately. So they're going to have a more difficult time breathing because they won't be able to create a nice negative pressure in the chest. Um, yeah, and what else? Then you have to have a working computer that's going to run that. So that's located in your midbrain and the medulla oblongata. So you need chemoreceptors that are working. Those are in your carotid sinus, your aortic arch, and up there in the medulla. The air going in and out is literally ventilation. So I know they used to call BVMs respirators back in the day. They used to call ventilators respirators back in the day. But air going in and out, the mechanical movement of air is ventilation. The exchange of gas is respiration, and respiration actually happens on the cellular level. So we got respiration happening in the cells, and we got ventilation happening as the air goes in and out of the body. And there's a difference between the two. If you have respiratory issues, like saturation problems, SpO2 problems, there's a fix for that. It's going to be FiO2 and PEEP. If you have ventilation problems, the rate is going to be rate and volume. We'll talk about those probably. What triggers us to breathe? Well, I mentioned chemoreceptors that constantly sample in the blood, and they're trying to detect increased levels of CO, which means you have more hydrogen ions and you have more acid, which inversely lowers the pH. So the pH going down doesn't mean there's less pH. That means there's actually more pH. I don't know who created this crazy system, but that's the system we have. That triggers us to breathe, and it's called a hypercarbonic drive. And when that happens, and it happens in real time, pretty quick, the diaphragm will drop, contract, rib muscles will then contract, spread the chest, creates a negative pressure area, and then the difference between pressure outside, atmospheric pressure, and inside causes air to move into the lungs. Some people who become desensitized to the levels of carbon in their body, like chronic lungers, COPDers, they will switch over to, because they have so much carbon that no longer triggers them, they'll switch over to a hypoxic drive. And then it's going off the O2 levels. And I think I've mentioned to you before, it takes a little bit of time to desat O2. If you ever want to try it out, put a pulse ox probe on your finger and then just hold your breath for as long as you can. And tell me if you see a drop in the SpO2. I doubt that you will. All right. So here's the anatomy of the brain. You can see the midbrain down there with the pons and the medulla. That's kind of that respiratory center. You also have the thalamus, your kind of temperature regulator in there. It's all protected very well by the brain and the skull. It's down there by the foramen magnum. So if they do have bleeding into the brain, it starts to herniate. That area gets pushed against the hole at the base of the skull, and that's why you have that change of respirations. We start talking about Cushing's reflex. You'll have hypertension, reflex bradycardia, and a change in respirations. Second rule of life, blood has to go round and round. So what does that mean? You have to have a working pump. You have to have working pipes. or a vascular system might be a better word. And then you have to have the right fluid inside the container, the size of the pipes and everything. Um, so yeah, you got to have a pump, pipes, and the fluid. Let's talk about Adolf Fick, the Fick principle of gas diffusion. So Adolf was trying to figure out how to get oxygen molecules from surface area A to surface area B. And one of the first things that he figured out is if he put more oxygen molecules on the first surface, that high concentration O2 will spread out to the second surface. And that's very similar to, say, putting someone on nasal cannula. If you have oxygenation issues, you're going to put them on O2. So the first thing we'll try, depending on the patient's stable or not, it's going to be some nasal cannula oxygen. The second thing that Fick figured out was if he moved the surface areas a little bit closer together, you have more oxygenation. And this is very similar to what happens with a non-rebreather mask. When you put the mask on their face and they exhale out, it exits these two little holes on the mask. It kind of provides some resistance you're breathing out against, and therefore it recruits a little bit of lung. It's actually providing just a little bit of PEEP, maybe 2 to 5, depending on whose opinion you're listening to. And this will actually recruit more lung. And the more surface area of your lung that you're recruiting, the more oxygenation will happen. And the third idea he had was, well, if he made both the surface areas a lot bigger and brought them closer together, more oxygen gas will exchange. And that's exactly what's going on with CPAP. When you place someone on CPAP, that's continuous positive airway pressure, they're giving them something to exhale out against. So it's the same thing as EPAP. CPAP and EPAP, they're all the same. So what happens is you recruit lung, and therefore you have more surface area available to exchange gas, and it helps with oxygenation. So when you think of CPAP, I want you to think of oxygenation. And when you think of um, oxygenation issues, the cure is FiO2 and PEEP. If you have ventilation issues, the cure is rate and volume for a BVM. I don't know if this will play. Let's see if it'll happen. Or if you'll be able to hear it while the thing's running. See, I don't know why that comes up. I don't know if I can play a video while you're on here, so maybe I'll try to do it at the end. So the videos that I show is it's Bob Page, and he's talking about capnography and how it is a real-time measurement of basically every function of the body we already mentioned. If you want to know if the medulla oblongata and the chemoreceptors are working correctly, you can use the capnography to detect that. Whether the rib muscles and diaphragm are working properly, all of the perfusion status of the patient. If someone's in cardiac arrest and they're in a low flow state, a low perfusion state, I want you to think of the CO2 as the exhaust of life. So it would be very low, but as soon as you obtain ROSC, that return of spontaneous circulation, you should see a big jump in the CO2 level because the engine has just been cranked up. Also think about this, like patients who are out in cold environments, they're going to be hypothermic and it slows metabolism. So guess what? The CO2 levels will drop. If you have someone who's hypermetabolic, has a fever, then you'll see their CO2 levels are elevated. And when they're hypermetabolic and running a fever, they're burning through oxygen and sugar in order to generate heat. So it's always a great idea to check a sugar with someone who has a fever or febrile seizure. They could be hypoglycemic just because they're burning off all that sugar to make heat. So, but why capnography? Well, South Carolina DEC requires it for all licensed agency. It's the standard of care. So therefore, it's required on every intubated patient, orally tracheal intubation. This is a AHA Class 1A intervention, and there's only a couple other AHA Class 1A interventions. That would be 12 lead EKGs and chest compressions. So, like, this is something that has been proven that it works, and it works great. And I try to use it on most of my patients because it is a window into all of their actual life functions. And I also mentioned the Air Force protocols. They require it also. Because I've had people say, well, on the Air Force Base, we're not the state of South Carolina. It's still required. All right. So why captainography? Captain. Capnography, because it literally measures everything in real time. In the class, I gave the example of a 12-year-old little girl that was hit by a car. They had the patient down in the CT scanner when I showed up to do the transport. The weather was bad. They were not flying. So we had to do it by ground from Toomey to Richland. And uh, the little girl had a closed head injury and maybe a liver lax. She had fluids hanging, blood hanging, um, the some pressors, and she was on a ventilator, and just as close to being as sick as you could get. So as we were loading that patient up on the stretcher, I noticed that they had a lot of volume going into her chest. Her tidal volume was set really too high for her size, and they were having blood pressure issues. Well, I could see why, because if you're putting all that intrathoracic pressure, you're just blowing that chest up, then you're going to decrease the preload, therefore decrease the afterload, the blood pressure of the patient. But I'm thinking, you know what? I can fix this out in the truck. I don't have to mess with it at the moment. As we're exiting out of the imaging and coming towards the trauma room to exit, the building, the nurse goes, "We've lost pulses. We don't have any pulses." Well, I spun around. The first thing I look at is the capnography. Well, it was, you know, 40 when we were in the CT scanner, and I turn around, it's still 40. So I know immediately that we have not lost pulses because the engine's still running at the same, speed that it was when we left the CT scanner. And your fingers will lie to you sometimes. Um, but this happened in front of the family, and they thought they just saw the little girl die. So when I turned around, I said, "No, we still have pulses." And the nurse was just persistent, so we had to pull him into the trauma bay. And the doc came in and got a femoral pulse real quick, and like, no, she still has pulses. So all that drama could have been avoided if people just had a basic understanding of how capnography works. So, so what I do for the little girl when I got in the truck, I decreased her tidal volume, and guess what? Blood pressure comes up. Everything starts to get a lot better because she didn't need all the volume in her chest, and she still maintained her saturations. I actually brought the volume down, and I turned the rate up, and I blew the CO2 off to down to 30 to 35. That way, I met my goals for a closed head injury patient. Let's talk about terminology. What's the deal with all these numbers? So first off, it is a number. It's called capnometry, and that's just the numerical value. You can see it on the screen here. It's the number 36. The normal value is 35 to 45, so this one's within normal limits. And then we also have this waveform at the bottom of the screen in yellow, and this is called a capnogram. And that waveform is going to tell us how the gas is leaving the body. So that will tell us whether we have bronchospasms or there's a whole bunch of things we can learn from this. This is just a different device so you can see what the screen looks like. That still has the capnogram there, and this device also had the capnometry together. It's called capnography. The end tidal CO2 is at the end of expiration. So when you see this waveform where it's going up, I like to think of it as being blown up. So they're blowing up. When they exhale out, they blow the line up, and when they inhale in, it drops back down to baseline. So the downslope and the bottom, the valleys of it, that is the inspiration phase, and the peaks is the expiration phase. Inhalation's down, expiration's up. Why else do we do capnography? There is simply no better way to confirm you have ET tube placement than waveform capnography, and that's period, end of story. Forget it. I've been fooled before on patients where I heard equal bilateral lung sounds, and then later I found out they only had one lung. Those sounds can be commuted across the chest. You can hear them. So you got to have waveform capnography in there because, like a doctor friend of mine told me, that placing the ET tube in the esophagus is not, the end of the world. And it's not a cardinal sin. It does happen, but it is a cardinal sin if you don't recognize it. And you will kill the patient if you have a misplaced endotracheal tube. So this is a window in the patient's ventilatory status. You not only will see um, what their breath rate is, so you can quit guessing, 14 every time or whatever number that you selected, 16. Every patient's breathing, 16 times a minute or 14 times a minute. You'll actually get to see it on the device. It'll give you a breath rate. Um, let's see. So at the top one here, we have 50. Our normal range is 35 to 45. So this has a lot of CO2. And you'll notice that they're breathing slow. So this would be hypoventilation. And on the bottom, that number should be like 19. I don't know why it's got 50, but they're breathing very fast. And that would be hyperventilation. So, what causes increases or decreases in CO2? Well, the increases are, think of the body like a motor. And if you get that motor running faster, the engine cranked up, you're going to produce more exhaust. Same thing here. If someone's exercising, there's a lot of muscular activity. Let's say they do cocaine or methamphetamines, things that crank that engine up, are going to produce more CO2. You have the beta 1 drugs, and beta 1 causes the heart rate to increase, and the beta 2 causes the lungs, enhances lungs and bronchodilation, and you can see some more increased CO2 from that. And some other things that causes an increase would be drug use, like when someone takes opioids and they basically stop breathing, or they're hypoventilating, they're breathing really slow, they're not blowing off enough CO2. You'll see seizure patients, whenever they're having a seizure, they're not breathing. And when they kind of, come out of the seizure, the first thing you'll notice is they're breathing deep and fast, going, and it's an effort to blow off those excess levels of CO2. So decreased CO2 levels, think about decreased muscular activity. So maybe someone is sleeping or resting, or if they are hypothermic, then their engine is kind of throttled back. Um, you will see decreased one with bronchospasm because they can't get the gas out of the lungs. So out on your mouth or nose, it's going to detect less gas. And then hyperventilation means you're blowing off too much CO2. So there's our normal cycle. You breathe in O2, you breathe out CO2. You have this kind of squared off waveform. If you compare the inspiratory phase to the expiratory phase, it's usually a 1-to-2 ratio. So this one here, it looks normal. There's that range, 35 to 45. Again, this is CO2, and this is a timeline. And depends on which book you're reading, you're going to see different letters and numbers. But basically, the end of inspiration would be A to B, and then they got a clear anatomical dead space. Then they begin actually exhaling, the air starts coming out. You'll have this alveolar plateau, and then you're in expiratory right there. And then you start to breathe again. Not very complicated. So these are common waveforms. This is normal. Like I said, if you look at the areas that are inspiratory phase, it'll be about twice as long as the expiratory. I'm sorry, the expiratory phase will be twice as long as the inspiratory phase on normal patients, normal breathing patients. When you have those asthmatics, those chronic lungers, you'll see a shortened inspiratory phase and an extended expiratory phase because they're trying to get the gas out. Asthma is an obstructive disorder. They can't get the air out. So let's look at the top here. The EtCO2 is at 48, and they're only breathing 8 tons a minute. So what's the fix for this? It's going to be to bag them. It's either going to breathe them faster or deeper, but they have a ventilation problem, so we're going to fix it with a bag, BVM. Down here for hyperventilation, the problem is the patient is blowing off too much CO2, and eventually they're not going to have CO2 in their blood to detect, and the brain will say, well, we don't need to breathe anymore. Usually they'll have a period of unconsciousness, and then they'll wake up and be breathing normally. Compare that to your seizure patient that has a period of unconsciousness, and then when they wake up, they're breathing deep and rapid breaths. And that really tells you the difference between the CO2 levels. One level, they blew off too much CO2 and then they just stop breathing until it normalized and they breathe normal. The other one is they have way too much CO2 built up from this, when they have the seizure, and then they have to blow it all off. I like to use the seesaw metaphor to explain CO2 and breath rate or respirations. As the breathing goes down, the CO2 rises, it goes up because we're not blowing it off. So that's hypoventilation. And then with hyperventilation, respirations are elevated, they're 35, and the CO2 levels drop. And eventually it's going to trigger your brain that you don't need to breathe. So some main reasons for the use of capnography: you can triage your asthmatic patients. Yeah, some people will fake symptoms. Well, you can't fake the waveforms. So it will show that they actually are having asthma attack without you having to ask me, pardon me, are you having an asthma attack? You can see it right there on the monitor. You can actually also see whether or not your beta 2 agonists are working. It's good for monitoring head injury patients because you want to keep the CO2 levels on the lower end, 30 to 35, because whenever they get the CO2 levels rise, they have cerebral vasodilation, which means you're going to have an increase in intracranial pressure and the patient's going to do worse. We monitor cardiac arrest and cardiac output, basically to see if we have decent chest compressions. You want to try to keep it, the CO2 levels around 20 or higher when you're working a code. But like I mentioned earlier, you can use that to monitor your perfusion status for patients. Even your trauma patients, you can use it for perfusion status, and also ET tube confirmation. There's no better way. Some terminology: these are all side streams. It's very common to see this on your LifePak 15s and Zols. One looks like a little nasal cannula. One fits on the end of an ET tube. I make a note at the bottom here that usually that side stream adds 50 mLs a minute of dead space, and your virus filter can add 50 mLs. If you add one of those Baxter inline suction units, that might be another 50 mLs. It's important to know this because let's say you're ventilating a very small patient, you're stuck on a transport because there's no critical care team available or no peds team available, and they're like, there's the patient's stable, it's no big deal. And you need to know the dose is around 6 to 8 mLs per kg. So let's say you have a 10 kg patient and you're going to vent them anywhere between let's see, I'm getting text while we're talking here to try to respond to these. Anywhere from 60 to 80 mLs would be your tidal volume. So let's say 80 mLs just to be kind of on the high end of it. So if I set my tidal volume at 80 mLs, 50 of it's going to go to fill up that virus filter, and another 50 of it's going to go to fill up the Baxter inline suction. So the patient's not going to get any you're not going to fill all the dead spaces that we've created by putting the appliances on the ET tube. Hopefully that makes sense. So you have to be able to account for all the dead space of the patient and all the equipment you're putting them on. Here's some asthmatic waveforms. You see the classic shark fin presentation. So the patient's having a hard time getting the gas out when they exhale, so it causes a slurring or a shark fin. And you can actually monitor whether it's a mild, moderate, or severe attack. So in a mild attack, they're going to be breathing fast. They appear to be blowing off CO2 due to that respiratory rate. You got the waveforms there, that shark fins. Well, in a moderate attack, everything actually looks normal. Respiratory rate's 20 and the end-tidal CO2 is 36. But this is actually a moderate attack. And then in your severe attack, you're going to see the rate of respiration starts to drop off and the CO2 level starts to go up. So this means they're becoming exasperated and they're not going to be able to compensate by breathing fast or deeper. So this is the time to get moving. This means the patient is fixing to stop breathing on you. Head injury patients, we want to try to monitor the CO2 levels because it could indicate what's going on for intracranial pressure. Your goal is 30 to 35. That doesn't necessarily mean you're going to bag them faster. You can bag them deeper. And you hopefully you know that head injury patients will generally present with hypertension and reflex bradycardia. So if you have a good blood pressure to work with, you actually get more bang for your buck off of ventilating deeper versus faster. So blood pressure dependent. If they don't have a good blood pressure, I would not give a lot of volume into the chest. But if they have a blood pressure you can work with, you would actually get better results by bagging that patient deeper, spreading getting those lungs really out, and pushing on squeeze on the inferior and superior vena cava. You're not going to tank their blood pressure. Or someone's not breathing. So for patients who are in cardiac arrest, this is a great way to monitor the effectiveness of chest compressions. Not breathing. It's funny. It says not breathing on my alert, but it says they're conscious and talking. So we want to try to keep it at least over 20. The statistics show if you can get someone greater than 30, then they're probably going to survive to discharge. Most of the codes I've worked, it's in the 20s, 20, 25. You might get 30 if it's a pretty fresh code, but I haven't had many much higher than that until they get rosted. It'll jump up to like 50, and then it works its way back to normal. For tube verification, if you lose the waveform, you're literally losing the tube. So this will help, even with that, the cuff, you can kind of monitor if you've lost the cuff on the ET tube using these waveforms too. And I think I might have a slide on that. So no waveform means no tube. Inadequate seal, here you go. This is exactly what it looks like if the cuff on the ET tube blows. They'll initially start reading the exhaled gas, and then it loses its seal, and then it just kind of dribbles back down to baseline. If you have an obstructed tube, that means the patient's like biting the tube, or I've seen it before where the tubing gets caught underneath the wheel of a stretcher, and you'll have these sharp points on it. That's an obstruction. Rebreathing their own gas, they're not exhaling fully, so that means they're not going to have good gas exchange. So let's see if you can figure out what this one is. All right, CO2 levels are too high and they're breathing too slow. So this is hypoventilation. This one, they're not fully exhaling all the gas and return to baseline. So that would be rebreathing. Oh, there we go. Well, this one's going to be an esophageal tube. We've lost the ET tube somehow. This is going to be the shark fins. And can you remember if this one is a mild, moderate, or severe attack? This one is a moderate attack. What about this one? The number looks good. It's between 35 to 45. It's nice and squared off. It's got a good I to E ratio. So that is just normal. I don't think these videos will play, but let me try. Nope. I don't know why it's doing that, but it was just Bob Page talking again that everyone's ignorant until proven stupid. Um, people don't want to learn capnography because they don't understand capnography, but it is a excellent tool. It's the only tool that we have that monitors in real time all the body systems at the same time. I'm not a fan of colorimetric devices. I finally got shawled to get rid of them. Why would I use this versus just using waveform capnography? I'm going to have the cardiac monitor with me no matter, if I'm in a ditch or somewhere else. And these things can be fooled pretty easily. So I'm not a big fan of colorimetric. Nasal cannula, tidal CO2 nasal cannulas are not the same as regular old nasal cannulas. So if you're trying to do like passive oxygenation prior to RSI or prior to placing advanced airway, then you do not want to end-tidal CO2 on their face. You want an actual nasal cannula on their face. The end-tidal CO2s basically provide blow-by oxygen to the patient. That's it. We rushed through it, but at least you can see all the PowerPoints. Go back through and watch it. If you have any questions, let me know. Catch you later.